Excellence in Healthcare Education and Delivery since 1911. Good morning, esteemed colleagues. It is my privilege to present to you today on the topic of lumbosacral spine radiculopathy and discopathy. Our esteemed institution has been at the forefront of healthcare education and delivery since 1911, and this lecture aims to further enhance our collective understanding of these complex spinal conditions. Learning objectives for the lumbosacral spine. In this comprehensive session, we will delve into the following key learning objectives. 1. Effectively asking key lumbar spine historical questions to gather relevant patient information. 2. Recognizing the presenting symptoms of lumbar radiculopathy, performing a valid lumbar examination, and verifying the diagnosis with confidence. 3. Understanding the unique presentation of a patient with a sequestered disc, and confirming the diagnosis through appropriate diagnostic measures. 4. Exploring the possibility of lumbar myelopathy and determining the parameters that define this condition. Radiculitis versus radiculopathy. Before we proceed, it is crucial to differentiate between two related yet distinct conditions, radiculitis and radiculopathy. Radiculitis refers to the inflammation of the spinal nerve root, which can produce pain and paresthesia, or abnormal sensations such as tingling or numbness. On the other hand, radiculopathy encompasses the properties of radiculitis, but also involves a motor deficit, or weakness in the affected muscles. It is important to note that the presenting pain and paresthesia symptoms may be identical in both conditions, making it challenging to distinguish between them based solely on these symptoms. Radiculopathy is determined during the physical examination, specifically through manual muscle testing. If weakness is detected in the relevant muscle groups, it indicates the presence of a radiculopathy. Unfortunately, the terms radiculitis and radiculopathy are often used interchangeably and incorrectly, leading to potential misunderstandings and misdiagnoses. If significant weakness is observed during manual muscle testing, and enough time has elapsed, an electromyography (EMG) study may be indicated to further investigate the radiculopathy. An EMG is a diagnostic test that evaluates the electrical activity of muscles and can help identify the specific nerve roots involved in the radiculopathy. The time frame for considering an EMG can vary depending on the severity and duration of the symptoms, as well as the patient's overall clinical presentation. L5-S1 disc pathology. When discussing disc pathology at the L5-S1 level, it is important to recognize that protrusions and extrusions do not always follow the idealized anatomical representations found in textbooks. These disc abnormalities can present in various forms, including central protrusions, lateral protrusions on either side, far lateral protrusions, or even multilobed protrusions. At the L5-S1 level, a lateral disc protrusion may compress and inflame the exiting L5 nerve root, while a more central protrusion may affect the S1 nerve as it passes through the S1 foramen. L4-L5 disc pathology. Similarly, at the L4-L5 level, a lateral disc protrusion can compress and inflame the exiting L4 nerve root, while a more central protrusion may affect the L5 nerve as it travels towards the L5-S1 foramen. During the physical examination, it can be challenging to determine whether the L4-L5 or the L5-S1 disc level is the primary source of the patient's symptoms. It is essential to consider the wide range of potential pain generators in the lumbar spine. This understanding will inform our diagnostic approach and subsequent management strategies. Your ability to accurately diagnose and manage spine pathologies, particularly those involving the lumbar spine, may determine your effectiveness in navigating the evolving healthcare landscape. Reimbursement for healthcare services is increasingly linked to the specific diagnosis, as represented by ICD-10 codes. This approach is an attempt to manage healthcare resources more efficiently. Reimbursement based on a diagnosis, or ICD-10 code, is a strategy adopted by payers to manage healthcare costs more effectively. By analyzing the data associated with each diagnosis, payers can determine the appropriate reimbursement levels. While this approach aims to incentivize providers who deliver high-quality care, it is also susceptible to potential abuse. Unethical providers may prematurely terminate patient care once the allocated funding is exhausted, regardless of the patient's outcome. There are numerous potential causes of low back pain, and the focus often centers on disc pathology. However, this narrow focus can sometimes be detrimental to the patient's overall well-being. It is important to recognize that many patients may have asymptomatic disc protrusions, or their acute disc protrusion may become asymptomatic over time. However, the patient may still experience persistent low back pain, indicating the presence of other contributing factors. Possible causes of low back pain include disc pathology, discogenic pain, spinal nerve root compression, radiculopathy, ligament injuries or strain, muscle strain or spasm, tendon problems, fascia-related issues. Other potential causes of low back pain include facet arthropathy, degenerative changes in the facet joints, Facet meniscoids, abnormal growths in the facet joints. Pars fracture, fracture in the pars interarticularis. Spondylolisthesis, forward slippage of one vertebra over another. Spondylolysis, defect in the pars interarticularis. Bone stress response, stress-related bone changes. Additional causes of low back pain may include subluxations, misalignments of the vertebrae, sacroiliac joint arthropathy, degenerative changes in the sacroiliac joints, metastatic lesion, spread of cancer to the spine, traumatic fractures, compression fractures, pathologic fractures, infection, discitis or osteomyelitis. Rounding out the list of potential causes of low back pain are arthritis, ankylosing spondylitis, inflammatory arthritis affecting the spine, kidney stones, abdominal aortic aneurysm, pancreatitis. When obtaining a patient's history, it is crucial to gather the following information: onset of symptoms, mechanism of injury if applicable, location of pain, pain level, using a validated scale such as the Visual Analog Scale, Verbal Analog Scale, Quadruple Verbal Analog Scale, or Numeric Rating Scale. Factors that exacerbate or alleviate the pain. Disability or quality of life scale/score. Lumbar spine. Let's consider a patient presenting with lumbar radiculopathy. How would you expect such a patient to present to your clinic? What would you anticipate finding during the physical examination? These questions prompt us to think critically about the clinical presentation and physical examination findings associated with lumbar radiculopathy, setting the stage for a deeper exploration of this condition. Valsalva effect? One key historical question to ask all spine patients is whether they experience the Valsalva effect. This refers to an increase in lumbar pain or radicular pain when coughing, sneezing, or bearing down. While the presence of the Valsalva effect is a common finding, its absence does not necessarily rule out the presence of a disc protrusion. It is an important consideration in the overall clinical picture. Key historical questions. When assessing a patient with suspected lumbar spine pathology, it is essential to ask the following key historical questions. Do you have radiating pain, extremity numbness, or tingling anywhere in your body? Asking this broad question allows the patient to provide unfiltered clinical information, which may indicate the presence of radicular symptoms. Have you been tripping or stumbling? This question aims to identify potential motor loss and the onset of foot drop, which can be a concerning sign in lumbar radiculopathy. A positive response to this question may indicate weakness in the muscles responsible for dorsiflexion of the ankle, leading to a dragging or slapping gait pattern. Do you have clicking or popping in your low back or a sense of movement? Translation. Clicking or popping sounds in the lumbar spine may be symptoms of instability, either translational or rotational. While lumbar instability is typically characterized by translational movement, these audible cues can help identify potential issues. It's important to note that the presence of clicking or popping may or may not be accompanied by pain. Do you have an increase in symptoms when walking uphill or up a ramp? This question aims to elicit information about potential nerve root irritation or compression. As the heel drops on an inclined surface, such as a hill or ramp, the L5 and S1 nerve roots may become stretched, often eliciting radicular pain. Patients may not associate their pain with this specific activity until directly asked about it. Is your pain worse in the morning, upon wakening, or worse in the evening? The timing of pain can provide valuable insight into the underlying cause. According to the allopathic model, morning pain upon waking is often associated with inflammatory or autoimmune conditions, such as arthritis. This is because the spine has been in an unloaded position throughout the night. On the other hand, evening pain is more commonly associated with mechanical issues, including disc pathology, as the discs and facet joints have been compressed throughout the day. However, it's essential to consider other factors that may contribute to morning pain, such as facet-mediated pain and hip flexor tightness. Patients with hip flexor tightness who sleep in a prone position may experience further compression of the facet joints, leading to a dull, aching low back pain upon waking. Disc pathology/discopathy. Let's now explore the various forms of disc pathology or discopathy. Disc bulge, typically broad-based. Disc protrusion. Disc extrusion. Sequestered disc. Disc protrusions can present in various forms, including central, left or right lateral, far lateral, and intraforaminal protrusions. It's important to recognize that these protrusions do not always conform to the idealized anatomical representations found in textbooks. While disc protrusions and extrusions can compress and inflame nerve roots, leading to pain, it's crucial to understand that many patients with these disc abnormalities may never experience low back pain or lower extremity pain. The presence of compression alone, often referred to as a pinched nerve in the mechanical compression theory, is not a reliable predictor of symptoms. The mechanical compression theory, or the concept of a pinched nerve, is no longer considered a primary factor in predicting symptoms. Numerous cases have been observed where patients have large disc protrusions with compressed nerve roots, yet they remain asymptomatic. These findings were often incidental on MRI scans. Neurophysiologists have challenged the validity of the mechanical compression theory in predicting symptoms. Instead, the chemical theory has gained prominence, suggesting that nerve root inflammation caused by inflammatory exudates from the injured disc is the primary trigger for symptoms. While the chemical theory is widely accepted, neurophysiologists acknowledge that an inflamed nerve root that is also compressed may result in more severe symptoms. It's important to note that even disc protrusions that do not appear significantly large can elicit substantial pain and radicular symptoms. This discrepancy between the degree of nerve compression and the severity of symptoms has been a point of debate between the spine surgical community and the neurophysiology community, ultimately leading to the acceptance of the chemical theory of inflammation as the primary mechanism. The management of a low back pain patient with disc pathology requires meticulous attention to detail. This includes obtaining a thorough history, performing a complete examination, considering appropriate imaging such as MRI and flexion/extension X-rays, and potentially ordering an EMG, electromyography study. Only after gathering this comprehensive information can an effective treatment plan be designed. It's important to understand that the outer one-third of the disc is innervated. Therefore, the disc itself is capable of generating discogenic pain, or pain originating from the disc itself. Some studies suggest that disc injury is primarily caused by axial compression rather than rotational forces. However, this data should be interpreted with caution. In some cases, patients may experience damage to the internal infrastructure of the disc, a condition known as internal disc disruption. Imaging of internal disc disruption may reveal normal disc morphology, but this does not preclude the possibility of discogenic pain. Internal disc disruption is often associated with annular fissures or tears, which can generate discogenic pain. There has been debate regarding the role of annular tears in pain generation, with some researchers believing that inflammatory substrates from these tears can inflame spinal nerve roots. However, others argue that annular fissures are simply signs of disc degeneration and are not necessarily associated with pain. The pendulum has swung in healthcare regarding the perception of annular fissures, ranging from being overlooked entirely to being considered the cause of pain in all cases, and finally, being viewed as a normal degenerative process. The likely truth about annular fissures is that they are symptomatic in some patients and asymptomatic in others. Patients can experience lumbar spine pain solely due to disc pathology. However, it can be challenging to differentiate discogenic pain from facet arthropathy and facet-mediated pain based on clinical presentation alone. Despite the traditional Netter-like approach to describing pathology, it is often very difficult to pinpoint the specific pain-generating level in the lumbar spine. In cases where all lumbar disc levels exhibit degenerative changes, and the patient reports intolerable back pain despite conservative treatment, the physical examination and imaging may not reveal the precise disc level responsible for the pain. In such situations, further diagnostic measures may be necessary. Discograms? Sometimes, the diagnosis of low back pain is not a straightforward process. For some patients, the unrelenting low back pain and lack of improvement become intolerable, necessitating additional diagnostic measures. Discograms, as described by Souza, were popular diagnostic tools over 30 years ago for visualizing the internal architecture and disruption of the disc. While their use declined somewhat after establishing this knowledge, discograms have regained popularity for a different reason. The discogram is now used to reproduce the patient's pain. The description you may encounter in a report is the discogram was concordant with the patient's pain, indicating that the discogram successfully recreated the patient's symptoms. Discograms are not ordered for all patients but are reserved for difficult cases where the source of pain is not clearly identified. These may include cases with multiple disc protrusions, facet arthropathy, foraminal stenosis, or other complex presentations. It's important to note that the discogram can only generate discogenic pain, as it specifically assesses the disc itself. There have been legal challenges to discograms ordered by chiropractors, as the procedure is often considered a surgical test. The underlying concern is that the discogram is used to determine the level at which a surgical procedure should be performed, and chiropractors are not surgeons. Therefore, some argue that chiropractors should not order this test. A case in point is when a chiropractor ordered a discogram, and the patient experienced complications. A surgeon testified that they would not have performed surgery on this patient even with the discogram data, rendering the test unnecessary. As a result, a lawsuit was filed against the chiropractor for ordering an unnecessary test that led to complications. It's important to remember that there are many factors that determine whether a patient is a suitable candidate for surgery, and not just the physical examination findings alone. Urgent/emergent signs. Let's now discuss the urgent or emergent signs that warrant immediate attention in cases of lumbosacral spine pathology. 1. Urinary retention. 2. Saddle paresthesia. 3. Unrelenting pain regardless of position. 4. Recent infection and current fever. 5. Trauma. 1. Urinary retention is usually an early sign of cauda equina compression. Loss of bladder control is typically a late-stage symptom of cauda equina syndrome. Urinary retention needs to be managed emergently, as it can indicate a serious neurological condition. 2. Saddle paresthesia, or abnormal sensations in the saddle area, can be a symptom of compression of the cauda equina. However, it's important to note that the absence of saddle paresthesia does not rule out cauda equina compression. 3. Unrelenting pain that does not increase or decrease with movement or changes in position is a concerning sign that should raise suspicion for underlying malignancy, such as cancer. Other organic pathologies like kidney stones can also elicit pain regardless of position, but these typically present with a consistent medical history. 4. A recent infection or current fever can be indicative of conditions such as osteomyelitis, bone infection, discitis, disc infection, septic joint, or cellulitis, skin infection. These conditions require prompt medical attention and treatment. 5. In cases of trauma, it is often said in healthcare that all bets are off. Trauma can create unique forces and mechanisms of injury that can lead to a wide array of spinal and musculoskeletal injuries. It's crucial to thoroughly inquire about the nature and severity of the trauma, as well as the location and characteristics of the pain, to make informed clinical decisions. A textbook case of a sequestered disc typically presents with an initial onset of low back pain and leg pain, followed by a cessation or marked reduction of low back pain, while the lower extremity pain worsens or remains unchanged. The cessation of low back pain, or a marked reduction, accompanied by persistent or worsening lower extremity pain, is a classic clinical presentation of a sequestered disc. This symptom pattern should alert you to the potential diagnosis. Many healthcare professionals, including patients, chiropractors, medical doctors, and physical therapists, may perceive the changes in symptoms associated with a sequestered disc as improvement. However, these changes actually indicate a worsening of the condition, necessitating further investigation. Imaging, such as an MRI, is necessary in cases of suspected sequestered disc. This is because the size of the sequestered fragment can vary significantly, and its location and degree of compression on surrounding structures need to be evaluated. An MRI is needed to assess the size and location of a sequestered disc fragment. The fragment could be as small as 2 mm by 2 mm by 3 mm, or as large as 25 mm by 15 mm by 18 mm. The size of the fragment matters because a larger fragment can occupy a significant portion of the lumbar central canal, potentially compressing the cauda equina. A sequestered disc fragment measuring 25 mm by 15 mm by 18 mm occupies a significant portion of the lumbar central canal, putting the patient at risk for cauda equina compression. This is a serious condition that requires prompt medical attention. If a large sequestered fragment is compressing the cauda equina, it is crucial not to wait for symptoms of cauda equina compression to manifest. Once these symptoms appear, it becomes a surgical emergency, and the patient may no longer have the opportunity to choose their preferred surgeon. Additionally, the potential for complete recovery of the cauda equina function is diminished once compression occurs. In a small percentage of cases, a sequestered disc may present initially without any low back pain. The disc fragment separates immediately, and the patient experiences lower extremity pain only. In such cases, the diagnosis becomes more challenging, as the typical clinical presentation is absent. Neural foraminal stenosis, or narrowing of the neural foramen, is a common occurrence in the lumbar spine. Decreased disc height and facet hypertrophy or osteophytes can contribute to this narrowing, potentially compressing the exiting nerve roots. In cases of neural foraminal stenosis, a patient may present with radicular pain, with or without accompanying low back pain. The patient may also report classic dermatomy-specific paresthesia or abnormal sensations. Typically, patients with neural foraminal stenosis caused by bony compression do not experience the Valsalva effect. This is because the Valsalva effect is more commonly associated with disc protrusions. However, it's important to note that foraminal stenosis can also be caused by an intraforaminal disc fragment, which may present differently. An intraforaminal disc protrusion typically presents similarly to a disc protrusion, unless the intraforaminal fragment is sequestered. In the case of a sequestered intraforaminal fragment, the patient may initially experience low back pain, followed by a cessation or reduction of low back pain, while the lower extremity symptoms persist or worsen. Imaging of an intraforaminal fragment can be challenging due to the complex anatomy of the neural foramen. MRI acquires averages of signals from various tissues, and the slices through the foramen must pass through multiple tissue types within a small space, including pedicle cortical bone, pedicle medullary bone, epidural vessels, epidural fat, spinal nerve root, disc fragment, pedicle cortical and medullary bone. The challenges in imaging the neural foramen may result in the MRI failing to reveal the intraforaminal fragment due to the various tissues present in this small space. In such cases, alternative diagnostic approaches may be necessary to establish the diagnosis. X-rays can often reveal foraminal stenosis secondary to osteophytes on the facet joints or facet hypertrophy. If foraminal stenosis is suspected, an MRI may be recommended to further evaluate the neural foramen. If the patient presents with a motor deficit, an EMG, electromyography, study may also be indicated to assess the specific nerve roots involved. When discussing neural foraminal stenosis, it is preferable to use the accurate terminology of neural foraminal stenosis or foraminal stenosis. The outdated term IVF encroachment should be avoided. Central stenosis, or narrowing of the central spinal canal, usually occurs in patients over the age of 50. However, there is an exception to this age-related pattern. The exception to the typical age-related onset of central stenosis is congenital central stenosis. Some individuals are born with short pedicles, resulting in a narrowed central canal from birth, as opposed to the acquired central stenosis that typically develops later in life. Central stenosis often presents with bilateral lower extremity symptoms, rather than unilateral symptoms. Multiple dermatomy involvement is common, and concurrent foraminal stenosis is often present. Patients with central stenosis may experience symptom improvement with flexion of the spine, as this position can help open the neural foramen. In cases of suspected central stenosis, obtaining an MRI and CT scan is recommended to confirm the diagnosis. Additionally, flexion/extension X-rays can provide valuable information about the degree of stenosis and any potential instability. In cases of severe pain associated with radiculopathy, co-management with a pain management specialist or through the use of acupuncture may be necessary to control the pain effectively. This co-management approach does not mean that you have lost your patient. Instead, it represents a collaborative effort to provide the best possible care for the patient, working together with other healthcare professionals. Co-management of pain may involve referral to a pain management specialist for interventions such as epidural injections, selective nerve blocks, or oral medication for pain management. Due to changes in societal perceptions and medico-legal concerns, many physicians may prefer referring patients to pain management specialists for prescription pain medication. Co-management of pain may also include offering acupuncture as an alternative or complementary option for pain management. Many patients may prefer to explore non-pharmacological approaches like acupuncture before considering medication. It's worth noting that acupuncture has also been shown to be effective in reducing nausea and vomiting associated with anesthesia and chemotherapy. Collective cancer concerns in the lumbosacral spine. 1. Patient age greater than 50 years, with exceptions. Previous history of cancer. 3. Unexplained weight loss. 4. Failure to respond to conservative care for 1 month. 5. Sometimes night pain and/or night sweats. 6. Pain regardless of position. These are collective red flags that should raise suspicion for potential malignancy or metastatic disease involving the lumbosacral spine. The lumbar spine is a common site for metastatic prostate cancer. If the history and physical examination raise concerns for metastatic disease, a Mr. Imaging study can be used to assess for compression of the spinal cord at multiple levels, as suggested by Bailey et al. in 2001. Additionally, a bone scan can help detect altered bone metabolism secondary to metastatic disease throughout the body. When performing the physical examination for suspected lumbosacral spine pathology, it is essential to include the following components: reflex testing, motor evaluation, sensory evaluation, provocative tests, nerve tension tests and mechanical tests, range of motion assessment, including end range loading if possible. Reflex testing is a crucial component of the physical examination. It is imperative to perform all reflex tests, including upper and lower extremity deep tendon reflexes, Hoffman's reflex, and ankle clonus. Do not let any healthcare provider or clinician convince you that reflex testing is unnecessary. Reflex evaluation is an essential part of the neurological assessment. Muscle testing should include the following: anterior tibialis, peroneus/fibularis, extensor hallucis longus, gastrocnemius, hamstring, gluteus maximus, gluteus medius, iliopsoas. Regarding muscle testing of the gastrocnemius, the manual muscle test may appear normal, 5/5, regardless of any deficit due to the superior lever arm of the ankle. Ask the patient to perform one-sided, weight-bearing plantar flexion. Start with the uninvolved side first, then the involved side. On the involved side, you may observe diminished height of plantar flexion, fatigue, and a harder impact of the heel and foot on the ground compared to the uninvolved side. When testing the gluteus maximus, the manual muscle test may elicit low back pain or sacroiliac joint pain. If the muscle being tested is weak and the test elicits pain, the finding is not valid due to inhibition secondary to pain. In such cases, you may not be able to test the gluteus maximus effectively. Ask the patient to perform prone unilateral hip hyperextension without resistance. If this causes pain, do not perform the manual muscle test. When testing the iliopsoas, the manual muscle test may elicit low back pain or sacroiliac joint pain due to the origin of the psoas major muscle on the vertebral bodies, transverse processes, and discs from T12 to L5. The contraction of the psoas major exerts force on the discs, potentially including any pain-generating disc. If this position causes pain, do not perform the manual muscle test. Instead, ask the patient to perform supine unilateral hip flexion as the iliopsoas test would be performed, but without resistance. In cases of radiculopathy, you should find multiple muscles that share innervation with a specific nerve root to be weak. For example, S1 radiculopathy, weakness in the gluteus maximus, hamstring group, gastrocnemius, and peroneus. Peroneus is shared with L5. Radiculopathy, weakness in the extensor hallucis longus, peroneus, shared with S1, and gluteus medius. L4 radiculopathy, weakness in the anterior tibialis, shared with L5, and quadriceps, shared with L2, L3, L4 L3 radiculopathy, weakness in the quadriceps, shared with L2, L3, L4, and adductors. Dermatomy testing is an essential component of the physical examination. While you may not make a diagnosis based solely on dermatomy findings, evaluating the dermatomes can provide valuable information to support your clinical diagnosis. Provocative tests should also be performed as part of the comprehensive physical examination. These include neural tension tests, seated, supine, and prone positions mechanical testing. Neural tension tests. Seated, beach terrouse, seated straight leg raise, or the slump test. Beach terrouse has 3 components. 1. Knee extension. 2. Knee extension with dorsiflexion. 3. Knee extension with dorsiflexion and cervical flexion. Supine, straight leg raise, SLR, coupled with dorsiflexion. Prone, femoral nerve traction test, which is also the L2-L4 neural tension test. Mechanical testing. Kemp's test. Laslet's tests explain the sacral thrust to the patient after the lumbar exam. Yeoman's test. Femoral anteversion/acetabular impingement (FAI) tests. End range loading. Lumbar myelopathy. Can a patient have lumbar myelopathy? This is an important question to consider in the context of lumbosacral spine pathology. Generally speaking, patients do not typically have lumbar myelopathy. However, there are exceptions which we will explore in the following slides. The spinal cord typically ends at the conus medullaris, which is located around the L1 level. Disc protrusions below the L1-L2 level may compress an exiting nerve root or the cauda equina, but not the spinal cord itself. The exceptions for lumbar myelopathy include a disc protrusion at or cephalad above, to the level of the conus medullaris, which can compress the spinal cord. A patient with a tethered cord, resulting in a low-lying conus medullaris, who has a central or large disc extrusion compressing and inflaming the spinal cord. Malingering. Exercise extreme caution when considering the possibility of malingering, or the intentional exaggeration or fabrication of symptoms. Be absolutely certain that you have fulfilled your duties as a clinician by obtaining a thorough history, considering all differential diagnoses, performing all indicated and suitable tests for the patient, and reflecting on any potential biases you may have brought into the examination room. Just because you cannot render a definitive diagnosis does not necessarily mean the patient is a malingerer. Instances of malingering are exceedingly rare. I acknowledge that there may be some discrepancy in your other classes regarding the topic of malingering. However, it is crucial to approach this subject with caution and objectivity. Souza cited authors who concluded that abnormal regional sensory or motor disturbances, such as symptoms affecting the whole leg or overlapping dermatomes, or widespread superficial tenderness, were unreliable indicators of malingering. However, these authors were effectively describing the presentation of complex regional pain syndrome, CRPS, which is a very real and serious pathological condition. Souza continued to cite the authors as identifying malingering or non-organic tests, to include axial loading in the standing patient, passive flexion of the hip with the knee flexed, rotational twisting of the trunk, and forward bending in the seated position, among others. We will discuss this perspective in class, as there may be valid reasons for these maneuvers to elicit pain in certain clinical presentations. I would not consider a patient to be a malingerer if any of the following caused pain. 1. Rotation. 2. Axial loading, see NCMX Research 3, passive flexion of the leg with the knee flexed. 4. Forward bending in the seated position. Before labeling a patient as a malingerer, which can have serious ramifications, it is imperative to perform your clinical, ethical, and legal duties to the best of your abilities. If you are unable to derive a definitive diagnosis, the appropriate course of action is to refer the patient to a healthcare provider, who may be better equipped to uncover the underlying cause of the patient's symptoms.